SGLT-2 inhibitors or sodium glucose cotransporter inhibitors are a new class of anti-hyperglycemic agents and are used for the improvement in glycemic control in type 2 diabetes mellitus. So in this video, I will be explaining the blood glucose lowering mechanism of SGLT-2 inhibitors and also some of the beneficial actions of these drugs beyond its glucose lowering potential. So now let's see with the help of this figure how these drugs act as blood glucose lowering agents. The drugs that belong to this class are canagliflozin, dapagliflozin, empagliflozin and etugliflozin. So these drugs, unlike GLP-1 analogs, are available as oral formulations. They are well absorbed from the GI tract and is filtered from the plasma at the glomerulus and reach the proximal tubule and gets attached to the luminal membrane of the proximal convoluted tubule. Now, in the proximal convoluted tubule, transporters known as sodium glucose cotransporter 2 is expressed in the tubular lumen. Now, the function of these transporters is to reabsorb sodium and glucose from the tubular lumen into the interstitium. So it causes reabsorption of sodium and glucose from the tubular lumen into the interstitium. So SGLT-2 inhibitors acting as anti-hyperglycemic agents inhibit the sodium glucose transporters, thus reducing the reabsorption of glucose, reducing the reabsorption of sodium, causing excretion of glucose and sodium in urine. In addition, SGLT-2 inhibitors also reduce the renal threshold for glucose, thus causing increased excretion of glucose in urine and glucosuria. So this leads to improvement in the blood glucose level due to reduced reabsorption of glucose and increased excretion of glucose in urine, thus improving the glycemic control in type 2 diabetes mellitus. Also, because there is loss of glucose and calories in urine, there is weight loss and therefore it is preferred in an obese individual with type 2 diabetes mellitus. The advantage of SGLT-2 inhibitors is that it provides benefits beyond its blood glucose lowering potential. So they have established cardioprotective and renoprotective action. So now let's look at the cardiovascular effects of SGLT-2 inhibitors. Firstly, these drugs are known to reduce the mean arterial blood pressure. So what is the mechanism underlying the lowering of blood pressure? As we have seen here, SGLT-2 inhibitors by lowering the sodium glucose cotransporter causes natriuresis, and increased natriuresis can cause intravascular volume contraction and decrease in blood pressure. Secondly, the SGLT-2 inhibitors by inhibiting the sodium glucose cotransporter causes natriuresis and increased delivery of sodium chloride to the distal convoluted tubule. In the distal convoluted tubule, there are specialized cells known as macula densa cells. These specialized cells communicate with the juxtaglomerular cells of the kidney. In response to high sodium chloride in the tubular fluid, these macula densa cells respond and send signals to the juxtaglomerular apparatus and decreases the release of renin. Because of decreased renin release, there is inhibition of renin-angiotensin aldosterone system. The inhibition of renin-angiotensin aldosterone system collectively works towards decreasing the angiotensin 2 formation and decreasing the aldosterone formation and decreasing the blood pressure. So in this way, through natriuresis and through inhibition of renin-angiotensin aldosterone system, it causes lowering of blood pressure. Secondly, these drugs have been found beneficial in patients with heart failure, both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So let's see how are these drugs useful in heart failure. As we have learned that SGLT-2 inhibitors cause excretion of sodium and glucose in urine, and because of increased delivery of sodium to the distal convoluted tubule, the juxtaglomerular apparatus receives the signals from the macula densa cells and reduces the renin release and results in inhibition of renin-angiotensin aldosterone system. So inhibition of renin-angiotensin aldosterone system decreases the angiotensin 2 formation, which is responsible for afterload. Also, there is decreased aldosterone formation, which is responsible for preload. So by inhibiting the renin-angiotensin aldosterone system, the formation of angiotensin 2 and aldosterone decreases, and this decreases the preload and afterload, the workload on the heart decreases, and this decreases the progression of heart failure. Also, these drugs improve the endothelial function and arterial stiffness and have a favorable effect on the vasculature by decreasing the oxidative stress. In addition, treatment with SGLT-2 inhibitors stimulates ketogenesis. So, in the process, beta-hydroxybutyrate, a ketone body, is synthesized and it is transported by the heart. It is taken up by the heart with the help of transporters. This beta-hydroxybutyrate, which is a ketone body, is utilized by the heart muscles, by the myocardium, instead of glucose and fatty acids. So, beta-hydroxybutyrate, a ketone body, serves as an alternative, less expensive fuel source compared to glucose and fatty acids, and this improves the efficiency of the heart muscle, increases the cardiac function, and helps in reducing the cardiovascular events. These drugs reduce hospitalization related to heart failure and death due to heart failure. They also decrease the overall cardiovascular mortality, improve cardiovascular outcome in patients with heart failure. The preferred SGLT-2 inhibitors in heart failure are canagliflozin and dapagliflozin. So, apart from the cardiovascular effects, SGLT-2 inhibitors also have renoprotective action. So, what are the underlying mechanisms that are responsible for renoprotective actions of SGLT-2 inhibitors? So, as we have learned that these drugs, by inhibiting the transporter protein, causes increased delivery of sodium chloride to the distal convoluted tubule, and in the distal convoluted tubule, macular denser cells are located. The macular denser cells are sensitive to the sodium chloride in the tubular fluid and sends signals to the smooth muscles in the afferent arteriole of the glomerulus that supplies blood to the glomerulus. So, by causing constriction of the afferent arteriole that supplies the blood to the glomerulus, it decreases the glomerular pressure, it decreases the blood flow to the glomerulus, decreases the intraglomerular pressure, decreases the excretion of albumin in urine. So, SGLT-2 inhibitors, by decreasing the intraglomerular pressure, slows down the decline in GFR in chronic kidney disease, also decreases the excretion of albumin in urine, and therefore it is preferred in diabetic patients, in diabetic nephropathy with chronic kidney disease. Also, it has been suggested that SGLT-2 inhibitors alter the factors that promote inflammation and fibrosis in the kidney, reduce kidney hypoxia, and also decrease the mitochondrial metabolism in kidney tissue. So, SGLT-2 inhibitors are approved in the treatment of chronic kidney disease in patients with diabetes mellitus and when GFR is greater than 20 ml per minute, because these drugs are known to reduce the decline in GFR, reduce albuminuria, improve the renal outcomes, reduce oxidative stress in the kidney, and is beneficial in kidney disease. The SGLT-2 inhibitors that have positive renal outcome are canagliflozin and dapagliflozin. However, a caution that needs to be considered is that patients with hypovolemia are at increased risk for developing acute kidney injury. Therefore, it is important to optimize the volume status of the patient before initiating therapy with SGLT-2 inhibitors. Also, because of increased excretion of glucose in urine, there is increased risk of infections, there is increased risk of urinary tract infections, and cases of urosepsis and pyelonephritis have been reported. So, to sum up the benefits of SGLT-2 inhibitors, these drugs improve glycemic control in type 2 diabetes mellitus, preferred in obese individuals because they produce weight loss. They have established cardiovascular effects and reduce the incidence of major cardiovascular events. They have renoprotective actions and are suggested in chronic kidney disease patients when the GFR is greater than 20 ml per minute. Some of the common adverse effects that are reported are urinary tract infections, genital mycotic infections such as vulvovaginal abscess, vulvovaginitis, candidiasis, and also cases of urosepsis and pyelonephritis has been reported. Secondly, there is increased risk of acute kidney injury in patients with hypovolemia. This is particularly important in elderly patients receiving diuretic and suffering from renal impairment. Thirdly, treatment with SGLT-2 inhibitors is associated with threefold increased risk for diabetic ketoacidosis. So before initiating treatment with SGLT-2 inhibitors, consider risk factors for diabetic ketoacidosis and also consider discontinuation of SGLT-2 inhibitor treatment in clinical situations that may predispose to diabetic ketoacidosis. Next, hypersensitivity reactions such as erythema, rash has been reported, and also there is increased risk of hypoglycemia, particularly when SGLT-2 inhibitors are combined with insulin or sulfonylurea, which is an insulin secretagogue. Also, these drugs have been known to increase the risk of hyperkalemia, particularly when combined with an ACE inhibitor or angiotensin receptor blocker. So these are some of the side effects that are associated with SGLT-2 inhibitors. So thank you for watching. If you find my video useful, please like and subscribe to my channel.